Right now, inside the stomach lining of a significant number of adults over 50, a process is underway that produces no pain, no nausea, no warning of any kind, and that is quietly destroying the protective architecture of one of the most important organs in the digestive system, setting the stage for consequences that range from nutritional deficiency to one of the most preventable and most dangerous gastrointestinal conditions that exists. Most people over 50 who are told they have a stomach problem assume it means acid reflux, an ulcer, or maybe a sensitivity to a certain food. These are the stomach conditions that get the most attention, the most advertising, and the most medication. But there is a category of stomach threat that is far more dangerous, far more silent, and far more consequential in the long run. One that does not produce the burning, the bloating, or the obvious discomfort that sends people to the pharmacy or the doctor. It grows in the stomach lining without announcing itself. It disrupts the body's ability to absorb critical nutrients without producing a single obvious digestive symptom. It creates the biological conditions for a cancer that is almost entirely preventable when caught early, and almost entirely devastating when caught late. And it affects adults over 50 at rates that would alarm most people if they knew, because most people have never been told it exists. The most dangerous thing happening in your stomach after 50 is almost certainly not the condition you have heard of, been treated for, or been warned about. It is the one that has been growing quietly underneath everything else. Think about how often you have dismissed a stomach symptom over the last few years. A feeling of fullness that arrived earlier in the meal than it used to. A vague, occasional discomfort in the upper abdomen that came and went without a clear pattern. An unexplained loss of appetite on certain days. Maybe some unintentional weight loss that you noticed, but attributed to eating less or being busier. These are the kinds of symptoms that most people over 50 file under getting older, eating differently, or stress. And for most people, that filing is correct. But for a meaningful number of adults, these exact symptoms are the earliest and most important signals of a process happening in the stomach lining that has a name, a clear biological progression, and a window of intervention that closes as the years pass. Today we are going to talk about that process, clearly, specifically, and in a way that gives you something genuinely useful. Here is what we are going to cover today. The stomach lining is not simply a passive container. It is a dynamic, specialized tissue that performs several critical functions, producing acid for digestion, secreting a protein essential for vitamin B12 absorption, maintaining a protective mucus barrier against self-digestion, and functioning as the first major checkpoint of the digestive immune system. The silent stomach threat we are going to discuss today is a condition called atrophic gastritis, a progressive inflammatory and degenerative change in the stomach lining that destroys these functions one by one, and the specific, dangerous cascade it sets in motion when it goes unrecognized and unaddressed. We will look at what causes it, what it does, what it leads to, and what the early signals are that most people miss entirely. By the end of this video, you will understand a stomach condition that affects a surprisingly large proportion of adults over 50, and that most people in this age group have never heard named. You will know what causes it, what it does to the body silently over years, and what the specific signals are that research has identified as worth taking seriously and reporting to a doctor. That understanding could be among the most practically important things you take from any health video this year. The silent threat, what atrophic gastritis actually is and how it begins. Atrophic gastritis is a condition in which the stomach lining undergoes chronic inflammation that progressively destroys the specialized cells that make the stomach function correctly. The word atrophic refers to the wasting away of tissue, specifically the glandular tissue of the stomach mucosa that contains the parietal cells and chief cells responsible for producing stomach acid and digestive enzymes. As these cells are damaged and destroyed by ongoing inflammation, they are replaced by scar tissue and by cells that are not native to the stomach. A process called intestinal metaplasia, in which stomach lining cells are gradually replaced by cells that resemble those of the intestinal lining. This replacement tissue cannot perform the stomach's specialized functions. It does not produce acid, It does not produce the intrinsic factor needed for B12 absorption. And critically, intestinal metaplasia in the stomach is recognized as a precancerous condition, a step on the progression toward gastric cancer that can be identified, monitored, and in many cases, interrupted before it reaches the point of malignancy. What makes atrophic gastritis particularly dangerous after 50 is the combination of two factors. The first is that it is common. Estimates suggest that atrophic gastritis is present in a significant minority of adults over 50 in developed countries, with rates increasing with each decade of age. The second is that it is almost entirely asymptomatic in the majority of people who have it. It does not cause the burning pain of peptic ulcer disease, does not cause the obvious reflux symptoms that bring people to the gastroenterologist, and does not produce acute symptoms that would prompt emergency evaluation. It simply continues, quietly, destroying stomach tissue year after year until the downstream consequences, nutritional deficiency, further metaplastic change, or, in the worst cases, cancer, become impossible to ignore. The stomach has an extraordinary capacity to compensate for early glandular loss. The remaining functional cells work harder. Acid production continues, though at reduced levels. Digestion continues, though less efficiently. The person feels essentially normal, or notices only the vague, easily dismissed symptoms already described. By the time atrophic gastritis is severe enough to produce obvious consequences, it has typically been progressing for years. Most dangerous cause number 1, H. pylori infection, the bacterial engine of stomach destruction. The most dangerous and most common cause of atrophic gastritis, and the one that drives the progression toward gastric cancer most directly and most powerfully, is a bacterial infection that most people have never connected to their stomach health, and that a significant proportion of adults over 50 are carrying without knowing it. The bacterium is called Helicobacter pylori, H. pylori for short, and its relationship to stomach disease is one of the most consequential and most thoroughly researched in all of gastroenterology. H. pylori is a spiral-shaped bacterium with a remarkable and uniquely dangerous adaptation. It is the only known organism capable of surviving long-term in the highly acidic environment of the stomach. It does this by producing an enzyme called urease, which breaks down urea in the stomach into ammonia, neutralizing the acid in its immediate vicinity and creating a protected microenvironment in which the bacterium can colonize the stomach lining. Once established, H. pylori burrows into the mucus layer of the stomach wall, attaches to the cells of the gastric epithelium, and triggers a chronic inflammatory response that the immune system is unable to fully resolve. Because H. pylori has evolved multiple mechanisms for evading immune clearance, including the suppression of the local immune response and the molecular mimicry of host tissue to avoid detection. This chronic, unresolved inflammation is the engine of atrophic gastritis. The sustained immune attack on H. pylori colonized stomach tissue produces collateral damage to the surrounding glandular cells. The parietal cells and chief cells are caught in the inflammatory crossfire and progressively destroyed. Over years and decades of infection, the stomach lining undergoes the stepwise progression that gastroenterologists call the chorea cascade. From normal mucosa to chronic gastritis to atrophic gastritis to intestinal metaplasia to dysplasia to gastric adenocarcinoma. Not every person with H. pylori follows this progression to its endpoint. The majority do not. But every step along this progression is driven by the presence of the infection, and eliminating the infection interrupts the progression at whatever stage it has reached. After 50, H. pylori infection that has been present for decades has had the longest possible time to drive this progression. Adults who were infected in childhood, which is the most common time of acquisition, particularly in populations with less consistent access to clean water and sanitation, may have been carrying the infection for 30, 40, or more years by the time they reach their 50s. The stomach damage accumulated over that duration is substantially greater than damage from more recent infection, and the risk of advanced atrophic gastritis, intestinal metaplasia, and gastric cancer rises directly with the duration of infection. The critical and genuinely hopeful piece of information is that H. pylori is detectable and eradicable. A breath test, a stool antigen test, or a blood antibody test can identify the infection simply, non-invasively, and inexpensively. When H. pylori is identified, a standard course of antibiotic combination therapy, typically 10 to 14 days, eradicates the infection in the majority of cases. Eradication of H. pylori at the atrophic gastritis or intestinal metaplasia stage has been shown in research to slow or halt further progression toward cancer, and in some cases to produce partial reversal of atrophic changes. The window for meaningful benefit from eradication is wide. Treating H. pylori at any stage before invasive cancer has developed produces measurable reductions in cancer risk. The infection is not a life sentence. It is a treatable cause that most people are simply never tested for. Research has consistently shown that eradicating H. pylori infection, even in adults who have had it for decades, significantly reduces the risk of progression to gastric cancer, and in many cases, stabilizes or partially reverses atrophic gastritis changes in the stomach lining. A 10-day course of treatment can interrupt a progression that has been building for 30 years. Most dangerous cause number 2, autoimmune atrophic gastritis and the B12 crisis it creates. The second major cause of atrophic gastritis is one that operates through an entirely different mechanism from H. pylori. And that is perhaps even more insidious in its silence, because it is driven not by a bacterial intruder, but by the immune system turning against its own tissue. This condition is called autoimmune atrophic gastritis, and it specifically and selectively targets the parietal cells of the stomach fundus and body, producing a progressive loss of acid secretion and intrinsic factor production that creates one of the most serious nutritional deficiencies affecting adults over 50. In autoimmune atrophic gastritis, the immune system produces antibodies that attack 2 specific targets in the stomach: the parietal cells themselves and intrinsic factor, the protein that parietal cells produce and that is essential for vitamin B12 absorption in the small intestine. As these antibodies destroy parietal cells over years and decades, 2 things happen simultaneously. Stomach acid production falls progressively, a condition called achlorhydria when it becomes complete, because parietal cells are the sole producers of hydrochloric acid in the stomach. And intrinsic factor production falls proportionally, because intrinsic factor is made exclusively by parietal cells. Vitamin B12 cannot be absorbed from food without intrinsic factor. It is simply not bioavailable in the quantities the body needs, without this carrier protein binding to it in the stomach and escorting it to the specific absorption site in the terminal ileum. When parietal cells are destroyed by autoimmune attack and intrinsic factor disappears, B12 absorption stops, regardless of how much B12 the person consumes in their diet. B12 stores in the liver are substantial. They can sustain the body for several years after absorption stops, which is precisely why the deficiency develops so slowly and so silently, and why by the time symptoms of B12 deficiency appear, the neurological and hematological consequences have often been accumulating for years. Vitamin B12 deficiency at the level produced by autoimmune atrophic gastritis is not a minor nutritional inconvenience. B12 is required for the production of myelin, the protective sheath surrounding nerve fibers throughout the body and brain. When B12 becomes severely deficient, myelin production fails, and existing myelin begins to degrade, a process called subacute combined degeneration of the spinal cord in its most advanced form. Peripheral neuropathy, numbness, tingling, and weakness in the hands and feet, is among the earliest neurological consequences. Cognitive impairment, memory loss, mood changes, and psychiatric symptoms can develop as B12 deficiency progresses and central nervous system myelin is affected. Megaloblastic anemia, in which red blood cells are produced abnormally large and dysfunctional due to the role B12 plays in DNA synthesis, produces fatigue, weakness, pallor, and shortness of breath. And the neurological damage from severe B12 deficiency, if allowed to progress far enough before treatment, can be irreversible even after B12 is replaced. After 50, B12 deficiency from atrophic gastritis compounds several other sources of B12 insufficiency that become more common with age. The reduced stomach acid production of early atrophic gastritis impairs the ability to cleave B12 from food proteins, a step that must occur before intrinsic factor can bind to B12. Proton pump inhibitors, among the most commonly prescribed medications in adults over 50, taken for acid reflux and heartburn, further reduce stomach acid and can contribute to B12 malabsorption from food. And the dietary B12 intake of many older adults is already borderline, particularly in those who have reduced meat consumption or who follow plant-based dietary patterns. Autoimmune atrophic gastritis is diagnosed through blood tests for parietal cell antibodies and intrinsic factor antibodies, tests that are not included in standard blood panels and that must be specifically requested. A low or low normal serum B12 level, in combination with neurological symptoms or unexplained fatigue in an adult over 50, is a clinical picture that warrants these tests. And once autoimmune atrophic gastritis is confirmed, the standard management involves regular intramuscular B12 injections, bypassing the absent intrinsic factor entirely, and endoscopic surveillance of the stomach lining for the intestinal metaplasia and dysplastic changes that this form of gastritis also predisposes to. Some people are wondering, if I take B12 supplements, does that protect me from the deficiency even if I have atrophic gastritis? Oral B12 supplements depend on intrinsic factor for absorption in normal doses. If intrinsic factor is absent, standard oral supplements are largely ineffective, and injectable or very high-dose sublingual B12 is required to bypass the intrinsic factor pathway. The supplement aisle cannot solve a problem that lives in the stomach lining, the gastric cancer connection, and why early detection changes everything. Having established the two major causes of atrophic gastritis, H. pylori infection and autoimmune disease, we now need to address the consequence that makes this condition genuinely dangerous rather than simply medically interesting. Gastric cancer, cancer of the stomach, is among the most lethal cancers in the world, not because it is inherently the most aggressive, but because it is almost universally diagnosed at a late stage in Western populations, where routine stomach cancer screening does not exist. And atrophic gastritis with intestinal metaplasia is the most well-established and most clinically significant precancerous condition in the stomach. The progression from atrophic gastritis to gastric cancer follows the stepwise sequence described earlier. Intestinal metaplasia, the replacement of stomach lining cells with intestinal-type cells, represents a significant increase in cancer risk compared to atrophic gastritis alone. Dysplasia, the development of cellular abnormalities within the metaplastic tissue, represents a further and more urgent escalation of risk. And invasive adenocarcinoma, the most common form of stomach cancer, arises from this dysplastic tissue after years of progressive cellular changes, driven by the ongoing inflammatory, bacterial, or autoimmune insult to the stomach lining. Gastric cancer in its early stages produces no symptoms that would distinguish it from the atrophic gastritis that preceded it, or from any other common stomach complaint. The vague upper abdominal discomfort, the early satiety, the mild nausea, the loss of appetite that may appear in early gastric cancer are the same symptoms that most adults over 50 experience at some point and dismiss without investigation. This is the clinical reality that makes stomach cancer so frequently diagnosed at an advanced stage. By the time pain becomes severe, by the time weight loss becomes significant, by the time the cancer is large enough to produce symptoms that feel genuinely alarming, it is typically spread beyond the stomach to regional lymph nodes or distant organs. The survival statistics for gastric cancer are a direct reflection of stage at diagnosis. Early-stage gastric cancer, confined to the stomach lining with no lymph node involvement, has a 5-year survival rate that research places above 90%, and in many cases is curable with endoscopic resection without major surgery. Advanced gastric cancer, with lymph node involvement or distant metastasis, carries a 5-year survival rate below 20% in most studies. The difference between these two outcomes is almost entirely determined by when the cancer is identified. And the cancer is identified earlier in people who are being monitored through regular endoscopic surveillance because their atrophic gastritis and intestinal metaplasia have already been diagnosed. This is the core argument for awareness of atrophic gastritis as a clinical entity. The person who knows they have intestinal metaplasia of the stomach and who undergoes endoscopic surveillance every 2 to 3 years, as research guidelines recommend, has a dramatically different probability of dying from gastric cancer than the person who has the same condition, does not know it exists, and presents to the emergency department 2 years later with abdominal pain and a CT scan showing an advanced gastric mass. The biology is the same, the outcome is not. Before today, had you ever heard of atrophic gastritis or intestinal metaplasia of the stomach as a serious health concern for adults over 50? Drop a yes or no in the comments. This is one of the most underknown and most consequential conditions in this age group, and your answer tells me how wide that knowledge gap actually is. The signals worth taking seriously and the tests that matter. Now let us talk about what to actually do with everything discussed today. Because awareness without action is simply well-informed anxiety, and that is not what anyone came here for. The symptoms of atrophic gastritis are subtle, vague, and easily dismissed. But they do exist, and they follow a pattern that research has identified as worth paying attention to in adults over 50. Persistent early satiety, feeling full after eating only a small amount, is one of the most consistently reported symptoms. Not occasional fullness after a large meal, but a consistent pattern of feeling satisfied or uncomfortable after amounts of food that previously required no conscious management. A vague, non-painful sensation of pressure or fullness in the upper abdomen that is not clearly tied to meals and does not respond to antacids the way acid reflux typically does. Unexplained loss of appetite over weeks or months. Unintentional weight loss that cannot be explained by changes in activity or diet. Even modest weight loss of a few pounds over several months that has no clear cause. Nausea that is mild, intermittent, and not associated with a specific food intolerance or a viral illness. On the neurological side, and this is particularly relevant for autoimmune atrophic gastritis, unexplained tingling or numbness in the hands or feet, a progressive difficulty with balance or coordination, unusual fatigue that is disproportionate to activity level, and cognitive changes, including memory difficulties and mood changes, can all reflect B12 deficiency developing from loss of intrinsic factor. These neurological symptoms appearing in the absence of other clear explanation in an adult over 50 should specifically prompt a B12 level check and a test for parietal cell antibodies. The tests that provide the most direct information about stomach lining health are relatively straightforward. A blood test for H. pylori antibodies or a stool antigen test for active H. pylori infection is simple and inexpensive. Blood tests for parietal cell antibodies and intrinsic factor antibodies identify autoimmune atrophic gastritis specifically. A serum pepsinogen test, measuring the ratio of pepsinogen 1 to pepsinogen 2 in the blood, is a validated blood marker for atrophic gastritis that has been used extensively in research settings and is available in clinical practice as a non-invasive screening tool. And upper endoscopy with biopsy, the definitive diagnostic procedure, allows direct visualization of the stomach lining and tissue sampling for histological evaluation of atrophic changes, intestinal metaplasia, and dysplasia. Who should consider discussing these tests with their doctor? Adults over 50 who have any of the symptoms described above that are new and persistent. Adults over 50 with a family history of gastric cancer, as the genetic risk factors for both H. pylori-associated and autoimmune gastritis increase familial risk. Adults who have used proton pump inhibitors for extended periods, as long-term acid suppression creates a gastric environment that may accelerate certain atrophic changes, and that impairs H. pylori detection by breath test if not appropriately timed. Adults with unexplained B12 deficiency, unexplained anemia, or unexplained neurological symptoms. And adults who have never been tested for H. pylori, despite living in or having origins from regions of high H. pylori prevalence, which includes most of the world outside of Northern Europe and North America. The conversation with a gastroenterologist or a primary care physician who is familiar with this condition begins with the symptoms, the risk factors, and the specific tests just described. It does not need to begin with alarm or with certainty that something is wrong. It begins with the question, given what I know about these conditions, does it make sense to test? That question, asked with the information from today's video supporting it, is the most valuable thing a person over 50 can bring into a medical appointment on this topic. Gastric cancer identified at the early stage, which regular endoscopic surveillance of known intestinal metaplasia is specifically designed to achieve, has cure rates above 90%, making surveillance not just a medical recommendation, but one of the most life-preserving investments a person with atrophic gastritis can make. The progression from atrophic gastritis to cancer takes years, and every year of informed monitoring is a year where intervention remains straightforward and outcomes remain excellent. Before we close, I want to hear from you. Did any of the symptoms discussed today, the early satiety, the vague upper abdominal discomfort, the unexplained fatigue or neurological symptoms, sound familiar in a way you had not connected to stomach health before? Drop it in the comments. And if you know someone over 50 who has been on long-term antacids or proton pump inhibitors, who has unexplained B12 deficiency, or who has been having vague stomach symptoms they keep dismissing, please share this video with them. This is precisely the kind of information that creates the early conversations that change outcomes. The stomach does not shout, but it does speak. And today, you learned to listen. Thank you for being here today. Take good care of yourself, stay curious, stay well, and I will see you in the next one.